It's actually very difficult to follow a talk like we just had, which has explained grief with such humor and such dignity. But my role is to try and talk about pregnancy loss less than 24 weeks. Now, although you'll have obviously noticed I'm a lot younger than Philip Steer, I've been working in the area of early pregnancy loss for about 40 years, starting in Glasgow when I was a registrar, and realizing at that time that the care and not only the medical care but the pastoral care around early pregnancy loss did not exist because diagnosis was made, people were sent away, etc. So I started early pregnancy services within Glasgow, and then when I moved to Leeds 24 years ago, we brought the services into Leeds to try and develop the overall care of women who present in early pregnancy and unfortunately lose that pregnancy. So what I want to do is talk about sort of some factual, some medical, and some sort of thoughts I've gained over this time, and to understand what the coping mechanisms and the problems of early pregnancy loss is, and what's different in some ways with that than, say, losing a baby at term, but also the huge similarities that exist. So let's have some facts. Now, the thing is that a spontaneous miscarriage is the spontaneous loss of pregnancy before 24 weeks gestation. Now, the problem of that is that 24 weeks is just a legal term of viability. It used to be 28 weeks in the past when I first trained, and it's moved down to 24 weeks because that's the legal definition of a viable pregnancy. So if a baby is lost before that, it is not registered, it doesn't exist as a legal entity. And that causes a huge problem, which I'll come back to, in the identity for the mother of losing that child, and the feeling that that the society doesn't really think that child's important. And it's because of the legalities of that, and the fact that they don't register it, it doesn't exist in the eyes of the law, the eyes of the state. Now, the next problem is that pregnancy loss less than 24 weeks is not a continuum. Most pregnancy losses occur before 12 weeks. About 90% of them will occur before 12 weeks. And between 12 and 24 weeks, only about 10% overall of the losses early occur at these times. Now, you can split it even further, in fact, is that 2/3 of those who lose a baby before 12 weeks lose that baby before 8 weeks. And it's only only about 1/3 of them will lose a baby between 8 and 12 weeks. Now, the problem of those losing a baby before 8 weeks is often the baby can't be seen. The sac may be seen, but the baby can't be seen. It's not because it's not necessarily been there or is there. It's because technically our ultrasound does not pick these things up. If you do biochemical testing of so-called empty sacs, there is evidence that babies are there or have been there or have developed but then been lost. So therefore, we talk about things of what we see. We talk about blighted ovum, we talk about empty sacs, because that's what we see. But these are all pregnancies. They're all babies that have started their life and then been lost. If you look after 12 weeks, then it's very rare, in fact, to lose a baby between 12 and 18 weeks. Most of the losses after 12 weeks occur between 18 and 24 weeks. Over the time of particularly cervical weakness, where the neck of the womb opens up, or problems of infection, or really actually premature labor, and the same reasons why it would happen if it was 25 weeks. But the difference at 23 weeks, that your baby is not an entity, so therefore it's born. If it's born dead, it never existed, and therefore you haven't had a premature labor, you've had a miscarriage. And it's all about words and definitions, which then cause a lot of the problems of families trying to cope with that. I'm not going to talk about molar pregnancy or ectopic pregnancy to any extent, but there are other pregnancies, again, which people have lost a baby. They've lost that pregnancy they feel where they're looking forward to and hoping for all the things which you hope for your own child. Now, molar pregnancy is particularly difficult, and also ectopic pregnancy, because the treatment's required for maternal health. Therefore, you're not talking about how to manage a miscarriage. You're talking about how to manage something to make sure the mother is safe. Because molar pregnancy can become malignant and cause death of the mother if not treated. Ectopic pregnancy, because of where it can be, may be dangerous to the mother. The problem for the mother is concerned, just because a procedure is being done for her benefit doesn't necessarily reduce the loss to the fact that she's lost a child. And plus the fact that in ectopic pregnancies, not only has she lost a child, she's also had some sort of operative procedure which has removed that child, which still may be alive actually at that point, just in the wrong place. And it causes significant psychological problems that she, in some way, is for her, she's sacrificing her child for her own safety. And it becomes that conflict of whether what she feels about that and how the guilt feelings that she may or may not have. So what are the emotions that are all tied up around this that people have? Now, the important thing is all pregnancy loss is the same. It's a loss of a wanted child. Now, it may well be the pregnancy wasn't planned. It doesn't mean it was not wanted. So it doesn't matter when that pregnancy is lost, whether it's at 12 weeks, 8 weeks, or 24 weeks, or term. It's loss of a child. The difference is of how that child relates to the environment round about it and who knows about it. Because if you, and also the length of time you're involved in the loss of that child. So in the situations where a child is unwell in the neonatal period, you've got a time seeing that baby, being with that baby, and seeing it being ill, and therefore the death is something which comes up on you, which doesn't reduce the loss, but you've got that chance to adapt in some ways. If you come in thinking you're pregnant and then scanned and told the baby has died, then that's a sudden just one big whammy of being told the baby, the dreams that moment before you had the scan were there, that have been removed from you. So it's a sudden loss. And the feelings that people have, and these are some things the Miscarriage Association have picked up, is that people feel tired, they're scared, they're guilty, they're shocked, they're crying, they're confused, they're jealous, they're numb, they're sad, they're depressed, they feel empty. These are all things that people say. Now, they're not things they all feel at the same time, and it's not things that everybody feels. People respond in different ways. But these are all things that have got to be coped with by the families and coped with by the staff around about it. We've got to acknowledge that and understand that and adapt our caring of people to the feelings that they have. And we find it very difficult when people are very distressed because it's always difficult to cope with somebody who is really very distressed in front of you. But equally, we find it very difficult for people who don't appear to have any reaction at all, because we want to sort of involve them and talk to them, but they're not talking to us. So we've got to adapt it and be able to respond to the feelings that people have at any given time, but also realize that this may not be the time they want to relate, and give them opportunities to relate at a different time, which is better for them and a better opportunity and space for them. So there's the classic sort of stages that people are meant to go through of grief and denial and anger, bargaining, depression, and acceptance. And the thing is, people will go through that. They will feel the grief. They'll sometimes deny that what they're being told. If they've been scanned and they say that your baby has died, but they say, I feel pregnant still. I still feel sick. I still feel all the symptoms of pregnancy. They want to deny that's true. And it's not for us to try and convince them their baby's dead. There is things we don't need to make that decision. We can carry people through and give them an opportunity for another scan or let them come to terms with what we're actually saying. There may be anger, and particularly you heard in the last talk, anger about something that could have been done that wasn't done, and don't understand of why do we not screen. Or so, and similarly, someone may have been to the GP the day before and said, I've got bleeding, and the GP says, don't worry about it, and she miscarries, and she thinks, well, maybe if I'd gone up sooner, things would have been different. They wouldn't have, but they feel that. They feel guilt, and they feel anger. They feel that the system has let them down. They feel anger about themselves. They think it was maybe that I had a drink that night when I didn't know I was pregnant. Maybe that was the factor. Or I carried on jogging, and I should have stopped doing that. They blame themselves for lots of things they did. And of course, it's important for us to say, no, that's not true. So we have to take people through the various grief points and the various emotional things that they express to us. But the important thing is that up to 12 weeks, the problem at that time, the pregnancy is a dream. It's with high expectation of where things are going to be. They're planning for the pregnancy. They're planning for what they're going to do. But they have no knowledge of the pregnancy apart from what they feel. They haven't necessarily shared that pregnancy with anyone, apart from obviously their partner. But they may have not told their friends, they may not have told their families, and then so the pregnancy is not, they're not shared. So therefore, when the loss occurs, the loss is not shared. It's very difficult to tell someone, oh, by the way, I'm pregnant, but I've now miscarried. So therefore, they keep it within themselves, and they try and cope within themselves. But other people around about them know there's something wrong because they're not behaving normally. But the thing is, they don't know what that is. A lot of people who are your friends might be irritated by your behavior and don't understand your behavior. And people often say there is no greater agony than bearing an untold story inside you. So these are people who feel they've miscarried, but then they have the problem of how do you relate? How do you tell people? Because you don't want to tell people something which is secret to you, or not necessarily secret, but personal to you. And you don't want to tell people in some way as if you're trying to tell them, to be sorry for me because I've miscarried. So therefore, people keep that within themselves. And there are a lot of people who feel this way. I have 3 members of my immediate family who all miscarried. And sometimes I didn't know at the time. Sometimes I get phoned because of who I am and what I am and for advice, etc. So the different people respond in different ways, but it's private. I know things about members of my family that no one else in my family knows about because they haven't discussed it with them. And it's a bizarre sort of almost secret knowledge that you've got that makes it often difficult in relating and talking to each other about it. The other thing is that I was very pleased to hear of the sharing of the grief that was described before, but many times in miscarriage that nobody seems to care, but even the guy who got me pregnant. And the problem of that is that the emotion for the partner is different than the emotion from the wife. The wife or the woman who's pregnant has felt the pregnancy. She's felt the symptoms. The pregnancy is real to her. As far as her partner is concerned, it's something he's been told. He may have seen the stick and the lines on it, etc., but pregnancy is still an abstract to him. The thing is, once his partner has miscarried, he sees the grief that his partner has, and he feels terrible for the grief of the partner, more so in many ways than the loss of the baby, because it's less real to him. The real grief and the real upset is seeing his partner in such distress. So often people find that the husband didn't know how to deal with it. So therefore they stop talking, and then if you stop talking, then distance starts to appear. The woman often feels that the husband doesn't care because he's not talking about it, but he does care. He cares a great deal about her, but doesn't quite know how to express that. So she needs his support and didn't know how to ask for that support, and he wanted to help but didn't know what to do. So therefore, it's important that everyone keeps talking, and talking in a way to try and explain how each other feels and to make sure that they share that, because they have no one else at this stage, because often no one else knows. They might have, if you've got a good friend that can be with you, that's very, very useful. Sometimes your friends are not useful because they don't want to know, they don't like to know this information, and therefore, or your friends are just newly pregnant themselves or have a baby, because it often comes in sort of in cycles like that. So often the only person that can really help you is your immediate family, and therefore it's important to keep talking. Now, there's no right way to feel after a miscarriage. And people to try and tell you how you should behave shouldn't do that, because you have to behave the way you behave and feel the way you feel. Different people react in different ways. Some people feel better quickly, whatever better means, and others find it takes a long time. And that's fine. That's what we have to do. And we all have to move that way and take the small steps required. So going through the sequence of grief and denial through to what acceptance is for you, it takes some people a very short time, it takes some people a long time. But what we can do as medical profession is that different points of that cycle, that we can give more information to them to help them. So the problem after 12 weeks is that it's slightly different, because often the pregnancy is then shared, and therefore the loss is shared. Often they deliver a baby, which makes it more visible, a physical loss to the partner and to other people. But then there's the problems of the law, which I've told you about, that being told it's not a birth because it's actually less than 24 weeks, it's therefore a miscarriage. And there are problems of that, and we have to be very careful of that, explain the law, but actually help in other ways. So it takes time to heal emotionally, and people have to be given the opportunity to do that the way they can, taking small steps towards the next stages, and to be able to break free of the feeling of being broken, being inadequate, being lost, feeling why can't I have a child? Why can't I carry a child? because these are not the questions that are relevant. It's questions you have, but not questions that are relevant. So what are the things we do? Now, there's three things. There's immediate, there's the aftermath, and the future. Now, the immediate is what you say. And the important things for medical staff and radiographers, etc., is being straightforward and open. And to say things, I can see the baby's sac, but I can't see the baby within it, or I can see the sac and see the baby, but there's no heartbeat there, and the baby seems to have died. And there's no soft way of telling people that. There's no way you can say anything which makes it easier for them. You can't soften the blow at all. So therefore, it's far better being open and straightforward. If you're not sure, or you want to, if the woman reacts by saying, I don't believe you, or are you sure, there's no reason why you can't scan her again in a week's time. And in certain situations, you should scan her again in a week's time to make sure that the sac you're seeing is not just a very early pregnancy. Because it doesn't matter. It's not dangerous for her to keep the pregnancy there. There's no reason to empty your uterus quickly. In the past, it used to be thought this was true because of infection. In fact, all the evidence suggests is that that's not valid. So everyone keeps telling me that I can get pregnant again and have another baby. But I wanted that pregnancy, I wanted that baby. So people say, oh, don't worry, it's only a miscarriage. You'll get pregnant again, you're young. Now, you don't say that to anyone who's lost a baby, a child, or necessarily, or something else. You don't sort of diminish it in some way by saying you can also have another child. Obviously, you can't say, if you've lost a parent, you can have another parent. But I mean, you don't say these things. You actually, you acknowledge the loss, and you say, I'm sorry, I'm really sorry for your loss. That's all that's required. There's no reason to say, don't worry about it, it's not important, because of course it's important. It's important to that woman, very much so. So what you say, you don't soften the blow. It's not only a miscarriage. You say sorry for the loss. It's a very specific thing, and then take people through as you go after that. Now, what we've got in St James's University Hospital in Leeds, which is true in most big units around the country, is we have a specialised early pregnancy assessment unit, which is open access. People can refer themselves, or GPs, or from A&E, where people are seen by dedicated nursing staff, who then arrange a scanning of them. And the scan is all important, because a scan can tell you. About 30% of all pregnant women will bleed in early pregnancy. Half of them will miscarry. The other half will not. So therefore, it's just as important in an early pregnancy service to reassure people that all is going well is to actually properly diagnose a miscarriage at a time when people can be given the support. Before ultrasound, people had to wait and see what happened. And in fact, many people were brought in for bed rest. I'm sure Phil remembers this as a houseman, that we had people in hospital on bed rest with bleeding in early pregnancy, and many of them will miscarry by 12 weeks, which is the natural time when a pregnancy is lost if it's not continuing. Nowadays, with ultrasound, we pick up a miscarriage far earlier than that, because as I said, 2/3 of women, the pregnancy fails less than 6 to 8 weeks. So often even at 12 weeks, even though the pregnancy is still there, the sac's still there, we can tell the baby died early because the sac's too small, or the baby might be there without a heartbeat and it's small. So we can say, well, you probably lost this baby at 6 to 8 weeks. And because that's when most of them do. But the problem is that the sac itself continues to grow. It's what produces the hormones. It's what produces the sickness. So therefore, the pregnancy, as far as the mother's concerned, still is present, even though the baby might have died and is not developing further. So the value of early pregnancy units is they can give clear advice and support accordingly at the appropriate time. Now, in the absence of an ectopic pregnancy, which has to be treated, and molar pregnancy obviously has to be treated to save the mother's life, there is no hurry to make this diagnosis. So if a woman can't accept the diagnosis, a repeat scanning a week, but you have to warn her that she'll have continuing bleeding, and not be over concerned by that. But the reassurance is that we will make a diagnosis in the time that she finds acceptable. So how do you manage it then? So there's various forms of management, of expectant management, medical management, aspiration procedures. And again, there is no hurry. If you actually go by expected management, 80% of women will have a successful miscarriage, but it may take up to 6 weeks for everything to come away. So therefore, that takes time, it's bleeding, it's uncomfortable, but she can do that if she wants. Many women don't want to have medication because they relate that to termination. They don't want an evacuation because similarly, they think the baby's been taken away from them. It's their decision of removing that baby. So they like to actually have an expectant management, so then they can feel that everything has come away itself and it's natural. But if you use medication, you get 90% chance within a week that it's successful, and aspiration is virtually 100%, but it's increased risk with aspiration. That's where infection comes in. It's where you aspirate. It's where something is put into the womb, and therefore you then, to help remove the products so they're there. So that increases the chances of infection and also things like perforation. But as I say, there is no hurry. So if someone doesn't want anything done, they wait for a week, see her back, and then have another discussion. Take her through the steps, so therefore she has no regrets in the long term. That's what's important. It's the emotional scarring of the future which is important. Now, many people want something to remember their baby by, and the important thing is, and this is especially true of babies in the 20 weeks, where there's this confusion over what's a baby and not a baby from a legal point of view, is that they're giving people a certificate to say that this person miscarried a baby or delivered a baby under our care before 24 weeks is very useful. We can give her scan pictures. The thing is to try and, often people leave hospital without doing any of these things. So just as we do in later pregnancy, keep these momentums in her notes. If she comes back, they're there for her to see. So therefore she can be reassured, she can be confirmed of actually what happened. There's books for remembrance in hospitals. You can plant flowers or trees. You can write a letter or the poem to the baby, all keeping mementos which are there forever. Because you don't get over this. You move on. But the baby was there that you lost is always going to be there. So it gives a focus and a memory for the life lost. So this is an example of a woman who delivered at 11 weeks in hospital, and she got a certificate, and that certificate is her proof that she labored and delivered this baby. And the sort of certificates can be like this. I first produced these in the mid-1980s in Glasgow for people who delivered late miscarriages, so they could have burials or other all the legal things which they need birth certificates or death certificates for. So simple things. It could be on official hospital notepaper or anything at all, just to say, yes, you had a miscarriage. Yes, you're right, it did happen. And this is proof to everyone else who requires proof that this was a miscarried baby. So what about the aftermath? Now, at the time, often women leave the hospital because they just want to go home into their family, to the arms of their family. And they ask before they get information, and they wished they'd been told more, they wished they'd been told there was more bleeding. So give them the opportunity to contact the unit. There are many units that will have follow-up telephone calls for people and to make sure things are okay. Keep the scan pictures and mementos so they can always come back from them, and give them support following the treatment, and particularly if they've got medical treatment, which requires ongoing support. The important thing to give them information. This is just a plot of miscarriages showing you from age along the bottom there, and the instance of miscarriages on the top. The yellow is people having their first miscarriage. The green color in the middle is the people having their second one, and the purple blue is the one having more than 3. And the first you can see is that miscarriage goes up as you go older, and we know that. But it still means the majority of people are still not going to miscarry. So although the chances have increased, they're not going to run into major problems in the future. The other thing is, although a second miscarriage occurs, the majority of people don't have a second miscarriage. And similarly, a majority of people don't have a third miscarriage. So therefore, someone who's had one miscarriage, the odds are very strong in their favor that all will be well in the future. And we can tell them that. That doesn't mean we dismiss them, but it's important to reassure them of that. Now, a lot of things we tell them, like things like, well, most people who miscarry have, half of them have chromosomal abnormalities. In some ways, that's meant to be reassuring. Well, there's 2 facts about that. One is half the people who have miscarriages, only half of them do the cells grow to actually then look to see the chromosomal abnormalities, and half of them have chromosomal abnormalities. So that's only 25% that we know about. It may be more, but we quote 50%. The second thing is that a lot of people then get concerned they're going to have an abnormal baby, and they're concerned about the probability of that in the future. Now, in fact, the evidence that shows if you do have an abnormal baby chromosomally in the first miscarriage, you're less likely to miscarry again. So in fact, it is true to a degree that these are one-offs that can occur. But we don't know that in most people. It's not worthwhile telling people something which might be true. And what we can say that really 80% of the time you'll be okay next time. So therefore, we can be reassuring, irrespective of how little we actually know why she miscarried. But the thing that's important is that to tell them about how a pregnancy develops, if it's an ectopic pregnancy, how it gets stuck in the tube, and the fact that it goes down into the womb there, and it then buries into the womb this sac, which buries in, and the baby develops within that sac. So therefore, that we can see that sac on scan, but up until 6 weeks, we cannot be sure that the pregnancy is not there. You can see a sac, but you can't reassure before 6 weeks, if you can't see a baby's heartbeat, that the pregnancy is not successful. And so therefore, that's why we tend to scan people at 6 weeks in follow-up pregnancies, because at that time, if you see a heartbeat, then that's very, very reassuring. So once they get implanted, and then the baby develops and we see it, then that's very, very reassuring. Now, the picture on the right tells you what happens by 18 to 20 weeks, showing you the membranes pushing down the cervix. And that's where the weakness on the neck of the womb occurs, at that stage. So weakness of the womb is not a problem early on. So stitches aren't of value before 18 to 20 weeks, because it's different mechanisms. And it's 18 to 24 weeks that may have cervical weakness and might benefit from having a suture put in. Once you have a scan at 6 to 12 weeks like this, then if the heartbeat's there, that's very reassuring. In those who a baby appears and then the heartbeat is lost, that's where the clotting problems and the antibody problems come in. And in this graph shows you that. The yellow line is women who lose their babies from 10 to 14 weeks. The red line is people who lose their babies from less than 10 weeks. And you can see that in general, after the first one, and any repeated losses relate to after 12 weeks of women with these clotting and antibody problems. They're not problems of people who miscarry early. So basically, before 6 to 8 weeks, it's an implantation problem. Between 8 to 12 weeks, it's often an antibody or clotting problem. Between 12 and 18 weeks, it's often infection and abnormality. Between 18 and 24 weeks, it's often cervical weakness, infection, or premature labor. So we then give advice to people about lifestyle changes. You keep weight gain to a minimum. You balance your diet. There's no fancy diets and other things or trace elements that show any real benefit. But you should reduce your coffee intake and caffeine intake. You should reduce your smoking and stop. You should stop smoking anyway, and reduce your alcohol intake. And these are not things that cause miscarriage, but they increase the chances of it. So by giving people advice, you can actually help them target that they're doing something which might help them be successful next time. There's no risk from sex in pregnancy, but if you are bleeding, you should avoid it. There's no risk of exercise in pregnancy as long as you did it beforehand. Don't suddenly start marathon running when you're pregnant, but if you are running, you can maintain it. Most marathon runners, in fact, have to stop to get pregnant, but also most marathon runners improve their marathon times after they've had a baby for various reasons. Swimming is a very good method because it's a weight-supported exercise. Work is not a problem, but you should reduce stress and try and have a controlled stress. And there's no need for bed rest itself, not of any benefit. So the future. How soon after the miscarriage should you get pregnant again? Now, there's actually no evidence of any best time. Physically, you can get pregnant within the month of a miscarriage, and there's no evidence that there's an increased recurrence rate. So from a physical point of view, there is not a problem. Emotionally, it varies between couples, and some people don't want to get pregnant immediately. Some people want to wait for a period of time, and that's up to them. They have to do it when they're comfortable. And normally we recommend 2 normal cycles, not because there's any scientific fact to that, it's just that it's a feeling that things are back to normal and it gives people time to think, etc. But if people get pregnant, it's not a problem. Scan in early pregnancy is very useful, but it's not really available in the NHS. You can try and arrange an early booking scan through the normal booking services, and there are also private providers. Except ectopic pregnancies, they should be scanned early to make sure the pregnancy is in the right place. But the value of a scan is, if you miscarried before 8 weeks last time, you have a 6-week scan, and the heartbeat is there, the evidence that we have is that 96% of people will take that baby home with them. So therefore, it's a very reassuring thing, that first scan. In fact, our more recent results are actually probably slightly higher than that. But it's so that very few will go on and miscarry, and some will have preterm labours, but 96% if you have a positive 6-week scan in most women who miscarry at one time. So the important thing is, though, is that overall this is that we as medical professionals can only do so much. We can give information, we can give support, we can do physical things. But in fact, the emotional things has to come from other people. We can do our best, but the relationship we often have with people, for people who come back in recurrent problems, we have a stronger relationship. But the relationship of family, of friends, are very, very important. The Miscarriage Association, which I'm actually a medical advisor for, is extremely important because it gives advice from people who've suffered miscarriage and understand a lot more than I do. And it's important that to be able to contact these organizations. The other thing is there are counseling available which can often help some people who require that. So the important thing is that pregnancy loss is pregnancy loss, irrespective of when it was. The difference is that how noticeable or obvious it is to the outside world. The importance of family, the importance of information, and clear, honest information from us is actually very important, that people can understand and know what's happening to them and their bodies, and have some idea of initially what happened to them, what we do about it, and in the future, what we do next. So all of this is something which is still developing. It's still not wonderful throughout the country, but there are some very, very good services to try and help this improve. Thank you very much.